Evening, everyone. Good evening. Thank you for joining us. What a Tuesday night it is. No word of a lie. I don't know what it's like where you are. It's tipping it down here right now. Hottest day of the year. An hour and a half ago, I was barbecuing in the rain. Misjudged that one somewhat. Anyway, it's good. We can put away the tongs and we can get down to doing some education, some medical education for us this evening. So thank you for joining us for this Hot Topics clinic. If you've not met me before, my name is Neil Tucker. I'm a GP. I work in Oxfordshire. I also work with MB Medical, obviously, and I'm also, in the context of some of what we're talking about this evening, I'm also the co-chair of the local Oxfordshire Greener Practice Group, and we'll be talking a bit about greener practice as we go through this clinic because of course what we're focusing on tonight is about optimizing, improving asthma care, but also thinking how we can do that in a sustainable, low carbon way. So joining me tonight to help out is Dr. Zoe Norris. Zoe, how are you?
I am completely splendid, Neil, because I feel very smug now to know it's raining where you are, because it's not here. It's glorious sunshine still up in beautiful East Yorkshire where I am. Like Neil, I'm a portfolio GP. I do the MB medical presenting. I do my clinical work through the medical chambers, and I'm medical director for Humberside LMC the rest of the week. And yeah, we have birthdays in our house this week. So not only is it sunny, but we've also got a hired hot tub in the back garden at the moment. I'm not thinking about the infection prevention and control aspects of it. I'm just going to go with it. And at the end of this, I'm going to be jumping straight in the hot tub. That's my cunning plan. So very much looking forward to this evening and very much looking forward to answering your questions, which I know Neil is going to tell you how to get involved shortly.
Sorry, I feel like we don't have time because we've got so much to get through tonight, but I'd love to unpick that, like hot topics in the hot tub. That could be a thing. I'm going to have a chat with the office about that. I'm going to get one sent to my back garden too. Nothing could go wrong. So what are we here to talk about tonight? We're here to talk about improving asthma care and thinking about that in a green, sustainable, more environmentally conscious way. And a lot of this evening is based around some fantastic work that's been put together by the Greener Practice Group. So if you've not come across Greener Practice, it is the largest network in the UK of GPs and primary care clinicians who are trying to make primary healthcare as sustainable as possible. And they've recently produced a fantastic asthma toolkit, which we'll talk a little bit about later on, and also a guideline as part of that on how to reduce the carbon footprint of inhaler prescribing. And the toolkit and this guideline, they've been endorsed by NHS England, Asthma UK, British Lung Foundation. So it's ticking all the right boxes. It's completely compatible with NICE, the SIGN and BTS guidelines as well. It's not trying to be a new national guideline. It's trying to add to the current existing national guidance that we've got. And this course has been commissioned and funded by NHS England and NHS Improvement, who have got who are having a big drive on trying to improve asthma care in the UK. So we hope tonight can be really interactive. If you've been on our clinics before, if you've been on our courses before, then you know we like to try and keep you entertained, keep you busy. Please do get involved in the chat. So you'll see you've got various little boxes on your screen. You've got the Q&A box, which Zoe will be, I was going to say manning today. I better think of a better word than that. It'll come to me at some point. That is where you can put any questions that you've got, but also if you want to share any experiences, if you've got a lot of knowledge in this area and you want to share some tips, then put it all in there. It's anonymized. It only comes to Zoe and I initially, but some of the most interesting things we'll share back with the group via that chat box. So do keep a look, or that Q&A box, I should say. So do keep a lookout for that. And also we'll collate some of the most interesting points of discussion and questions to have a little bit of breaks at various points throughout this evening, and do like a little Q&As, and Zoe will bring those in. We also are going to have a few polls, and we're going to do these online MCQ polls. And I just want to get a little bit of practice with that at the very start. So here's the question. What type of clinician are you? Who's joining us tonight? I'd really love to know who you are out there. So you'll see various options on your screen. So you can just click on the little circle next to the one that fits the bill for you. So are you a practice nurse or advanced nurse practitioner, a clinical pharmacist, a physician associate? Are you a GP, or maybe you're on the VTS scheme? Are you something else entirely? You're something else entirely. That's fantastic. I've ran out of boxes to put stuff in then, but please do let us know. You can say hello in that Q&A box, and be really interesting to hear from you. So I'll give you a few seconds just to get your answers in. Whilst I'm doing that, I'm going to rearrange my screen so I can see what's going on. I've got like a little kind of live demonstration of the polls as they go on. I like to give you a few seconds so you can get your answers in, but actually fabulously, you guys are really, really fast this evening, which is great because boy, do I have a lot to cover in 1 hour. So let's have a little look at the mix of this evening then. So we've got mostly GPs, possibly no surprise, but great to see we've got loads of practice nurses and pharmacists as well. We've got a few physician associates, a few associates in training as well, and some others. I'll pick those up in a bit. So that's fab. Okay, so you've got the idea of the polls. That's brilliant. We'll do a few more of those with a more clinical emphasis as we go on through the next hour. Just a bit of housekeeping. We don't need loads of introductions for these clinics, but just so you know, this is being recorded right now. So this is going to be on the website. So you can go to mbmedical.com, log into your dashboard there and watch it back on demand. It will continue to be free. And so if you find this evening helpful, please do share this with your colleagues as well. Even if they can't make it tonight, they'll be able to come and watch it at some other point over the next year or so. Also, when I'm just talking about those boxes on your screen, one useful box to be aware of is the resources tab. So in the resources tab, I put a whole bunch of links to some of the background research we'll be talking about, things like the Greener Practice website, some of the stuff when we're talking about, we'll briefly be touching on things like QOF and PCN DESs and stuff like that later on. Loads and loads of tabs, loads and loads of links in there. So please do have a look at the resources tab. And also, if you've never checked out the Greener Practice website before, then I'd highly encourage you after this to go and have a look at it. Loads of really useful information over there. And if it's something that you're interested in, then have a think about seeing whether there's a local group. You don't need to do a lot of work. You don't need to, it's not going to be time consuming. Most local groups do a meeting every 1 or 2 months to share ideas and thoughts and a bit of moral support as we're trying to navigate this tricky time. It doesn't have to be arduous. It's a really nice thing to do. If you don't have a local group, maybe think about setting one up. So I did that with a colleague, Angela, about a year or so ago. And it's been really, really good. So very straightforward to do. And they do talk about that in the website in a bit more detail. So why are we here tonight? 2 reasons. So firstly, asthma outcomes in the UK. So the problem we've got is that they're kind of going in the wrong direction. We've been seeing this increase in the rates of asthma deaths over the past decade. So by the sort of 2010s, things had been improving, and then since then they seem to have got steadily worse. We run out of data in the pandemic. It's highly unlikely that things have got any better during the pandemic. And we've now got some of the highest asthma death rates in Europe, which is not a great place for us to be. In 2014, there was a big national review of asthma deaths, trying to understand the reasons behind why this was happening. And when they looked into it, they found that actually probably 2/3 of the deaths from asthma were potentially preventable, and particularly children and young people. When they reviewed the deaths there, they found that only 1 in 28 of those children or young people they felt had been adequately managed. So there's definitely lots of room for improvement. Yes, we're doing lots of really good work, but it's also really important to identify those who are at highest risk. So we want to try and improve asthma outcomes. At the same time, we're mindful about the environment. Very high on our agendas at the moment, high in all of our minds. I suspect that most of you who are joining us tonight buy into the idea about a climate crisis. and the effects that that's having on the world. And there's no doubt that the climate crisis negatively affects people's health in a wide range of ways, but particularly with respiratory disease, we're already seeing the kind of like the effects of various elements of the climate crisis. It's not just about carbon, global warming. There's issues around pollution, biodiversity, things like that. And all of this negatively affects people, but it's happening already. So I think that everyone, I'm sure, joining us this evening sort of buys into that idea and wants to try and help with making sure that it doesn't get too bad in the future. The other thing we know about is that the climate crisis affects some people more than others. And so it's driving health inequalities. Those who are in a financially better position, no doubt have more means to mitigate some of the effects of the climate crisis than those who are not in such a sound financial position. And that's true for different countries around the world, but it's also true for individuals in the UK who are at different ends of the socio-economic spectrum. There's a lot more about that on the Greener Practice website. It's well worth having a look at. We haven't got time to go into all of it today, but it's certainly worth us thinking about. Why is it important for us in the health service? 5% of the UK carbon emissions are linked to the NHS. The NHS does extremely important work. No one's saying we should stop healthcare, but there is a big question about whether we can do healthcare in a more sustainable fashion. And the NHS is a world leader in healthcare in trying to reduce carbon emissions. They've already made this target to be net zero by the emissions that the NHS directly controls by 2040. But I think we also appreciate that the next decade is really crucial. So those targets that we see from the sort of on the international stage for 2040 to 2050, that's great, but actually we need to be doing things faster. And so it's really good to know that there's also this drive from the NHS to reduce carbon emissions by 80% by the end of this decade. And to achieve that, all parts of the NHS are going to need to be involved, and including general practice. So why asthma in the environment? Well, it's because of the disproportionate effect that little inhalers have on the total NHS emissions. So they account for 3% of total emissions, and that has that's a big proportion of general practice emissions. So the majority of general practice emissions are linked to the prescribing that we do. A significant proportion of that is purely inhalers. So they account for somewhere between 20 and 25% of general practice's emissions, which is why there's been such a big drive on thinking about the inhalers that we're prescribing. The biggest issue, of course, is around metered dose inhalers. They're the major contributor. It's the hydrofluorocarbons that make up the propellant in those inhalers. They are significant greenhouse gases. They are 1,000 to 3,000 times more potent than CO2. So a little bit in your inhaler goes a really long way. And we also know that the issue in England is that the majority of inhalers prescribed are metered dose inhalers. That figure of 70% is for all inhalers. But I suspect if we just think about asthma, and a lot of what we're talking about tonight can be applied to all types of respiratory care. But if we particularly think about asthma, then I suspect actually the proportion of MDIs may be even higher than that. The good news is there is a double win here. So can we improve asthma outcomes and help the environment at the same time? Absolutely. These goals are not polar opposites. They are entirely complementary. The win here is that if you have well-controlled asthma for your patient, then that equals better outcomes for them and lower resource uses overall. So someone who's got well-controlled asthma, they will have fewer GP, fewer hospital appointments. They'll have less inappropriate inhaler use. It's possible that their inhaler use might go up overall, but they'll be using the right ones to make their outcomes better, and that's probably going to be better for the environment as well. Their treatment burden will decrease, so patients will need to have less follow-up, less appointments with us. That's great for them. That's great for us. And if we can help educate our patients, then that improves things like self-management, which also then improves care, improves their outcomes, and further decreases the ever relentless increase in demand for us in primary care. So how can we achieve that well-controlled asthma and that help for the environment? And of course, I think a lot of focus on this over the past, because it's been quite topical over the past 3-4 years now. A lot of the focus has been on inhalers and the type of inhalers that we're prescribing. There's financial incentives for us to change inhalers that we're prescribing in practice now as well. But that's only one part of it. And actually the first part, the most important part, when we're thinking about how we can get that double win, is simply to optimize people's care. And that's not just true for asthma, that's true for, I suspect, any condition you can think of. If you can make people the healthiest they can be, then that's the best way to help them and to help the environment as well. So after we've optimized their care, then we can think about which inhalers are most clinically appropriate to help improve that person's care and to minimize the carbon footprint. The reality is we're probably doing all of this at the same time, but we're going to think about it in stages tonight. Let's meet our patient of this evening. This is Sarah, 23 years old. She is a trainee accountant. She's a keen netball player, and she's had asthma since she was a child. She's been living with this for a long time. She describes it to you as mild asthma. She's never needed to go to A&E. She's never been hospitalized. But she does get flares in the winter. So when she gets a minor ERTI, then that seems to trigger off her asthma a bit. And she does lots of exercise, runs a couple of times a week. She plays netball a couple of times a week. And she usually gets wheezy when she's exercising, particularly in the winter with the cold air. So her current asthma regime is Clenil. She takes 100 microgram dose, 2 puffs twice a day. And she takes salbutamol, meter dose inhaler as well. And you can see from her medicines page that she's used 3 inhalers of Clenil over the past 12 months. So she's not taking that regularly. She actually seems to take that, when you quiz her in a little bit more detail, for a month or 2 after she'd had one of those flares in the winter. Things seem to settle down, and then she reverts back to using her salbutamol, which gives her quite a lot of very quick relief. So she uses 4 inhalers per year of salbutamol. So let me ask you our first poll question then. So how many salbutamol inhalers per year do you think indicates poor asthma control? And what I'd like to know here is not, when we're doing these polls, it's not so much about what do you think the guidelines say or what have you read in guidelines, just what's your own personal clinical opinion? What makes you think, actually, that's not great. That's maybe something we need to try and address. So would you say 1 or more, 2 or more, 3 or more, 6 or more in a year, or 12 and more in a year? What would you say is a marker of poor asthma control? So remember, these polls are entirely anonymous, so you can tick any box that you want. Don't be scared about putting an answer in if you're not sure. And as I say, there's often not one specific right answer with many of the polls we're doing. It's more about trying to get a feeling for what we as a collective in primary care feel is kind of the normal, kind of like the normal way that we practice. What's the sort of the regular way to do this? The last few seconds to get your answers in. Let's take a look. Okay, so what's that? 40% of you. The majority of you saying 3 or more, and then 28% of you going with 6 or more, a few with 12 or more, and then a few with 1 or 2. Okay, so that's quite interesting. Keep those figures in mind as we go through the next section. So let's have a little think about optimizing asthma care. So this is the top priority. Identifying people with poorly controlled disease and then just trying to make it better. So that raises a question then. Why do people have poorly controlled asthma? We've got guidelines, we've got a wide range of treatments. Why is it that people still have poorly controlled asthma? And there's a range of different factors here. This may not be, this is not an exhaustive list. And it'd be interesting to see. Do please put in the Q&A about what you think has an impact on here. What's your experience with this? But here's some of our thoughts on this. So, firstly, I think that there is a failure to maybe understand what asthma actually is. So lots of patients know that it's a problem with the lungs, it makes them wheezy, but actually I also think maybe a lot of them don't appreciate that it is an inflammatory condition. There's inflammation of the airways, and what that tells us is that the treatment of asthma is therefore to control the inflammation. And that's really important information that people need if they're going to actually manage it correctly, because failure to understand that then leads to short-acting beta agonist overuse. So almost exclusively in the UK, that's going to be salbutamol. So lots of patients rely almost exclusively on their salbutamol, which is a bad place to be. So that's linked with inadequate use of regular inhaled corticosteroids. And of course, we know that the steroid component here is the life-saving part of this. It's that's what's dampening down the inflammation, preventing the exacerbations, preventing those acute asthma attacks. So I should mention at this point, as we're going through this evening, a lot of what we're talking about, I think, is highly applicable to adults. So from 16 plus, some of it may be arguably from 12 plus. Some of this I wouldn't necessarily, particularly when I'm talking about the inhaler choices, I wouldn't necessarily, some of the options that we're talking about here are not licensed or necessarily recommended in young kids. So let's tend to think about this more as kind of like adolescents and adults. But there are some basic principles here that I think sort of carry over through all groups. So if you've got 3 days per week that you're needing to have your short-acting beta agonist, that's a pragmatic threshold that many people would consider indicates uncontrolled asthma. Even that, arguably, I think is too much. I think if people are using 1 or 2 SABA inhalers a year, that would be okay. Lots of people use more than 6. I think most, there's not specific guidance here, but most, in the Greener Practice toolkit, they talk about if people are needing 3 or more, then that's a marker of 3 or more inhalers per year. That's a marker of poor practice. Here's a simple practical tip that you could do. So when we prescribe medications, it automatically decides on a prescribing interval. And normally that defaults to 28 days. Why not, if you're prescribing salbutamol, just change that prescribing interval? You put it as 90 or maybe even better, 180 days. When someone's then asking for their inhalers again sooner than that, that's going to actually just flag up to us. It's going to make it a bit more obvious that this person might be overusing their treatment, and we need to think about reviewing their asthma care. Number 3, poor inhaler technique. So I think this is a fascinating area because I have been absolutely guilty of this. I've never understood, it turns out, the best way to use an inhaler. I don't have asthma. I've never used an inhaler. Most clinicians will not have asthma. Most of us will have never had any formal training. There's also loads of different asthma inhalers now, and all of them have slightly different techniques that they use. But there are some broad principles that are quite important to know. So let me ask you a question. So Sarah's got her metered dose inhaler. So that's the salbutamol. Gives it a shake. She presses down on the canister and she breathes in at the same time. But what's the best way to breathe in and optimize that delivery of medicine into the lungs where it's needed? So would you suggest that she should do a quick and deep breath over 2 to 3 seconds? So, or would you do a slow and steady breath over 3 to 5 seconds? So as you're pressing down, we're going more. Fill up the lungs slightly more slowly. Both of them, you're going to be holding the medicine in as long as you can. Try and do it for 10 seconds if you can, then breathe out. What are you going to do? What are you going to do for this? And I'm definitely guilty of not really understanding this, I have to say. So once again, there's no judgment here because I thought I'd been doing asthma care pretty well over the last 12 years of my GP career, 15 including all that VTS stuff where I was seeing patients as well. Let's have a look at your answers. Okay, so most of you going for 85% and 15% of you going for the quick and deep breath. So actually, you guys are pretty good because that slow and steady breath is the best way to do a metered dose inhaler. I have to say, until recently, that was news to me. So a really important thing we can do for people with poorly controlled asthma is just review their inhaler technique. Metered dose inhalers are quite difficult to get the technique right, and they've done research into this and found that actually most people don't do it correctly. It requires that slow and steady breath in. Dry powder inhalers actually tend to be easier for the majority of people. Not everyone will get on with every inhaler, but generally speaking, dry powder inhalers are a bit easier to use to coordinate what you have to do and your breathing as well. They require that short, sharp breath in. So that's what most people, most patients actually do for metered dose inhalers. They kind of go trying to capture the speed of the propellant, which you'll never be able to do. But actually, that's the correct technique pretty much for a dry powder inhaler. Spacers, of course, are really important. So if someone's using a metered dose inhaler, using a spacer will reduce those errors. It can help reduce those errors with technique, and it improves the efficacy overall. They're obviously really important to use in young children who just won't be able to get on with any kind of inhaler that well. But they're also good for everyone. I mean, if you're using a metered dose inhaler, ideally you'd be using a spacer every time that you use it. If people are really struggling, then maybe try a different inhaler. Maybe they just need to use something else, find an inhaler that they can use, and then they'll have better technique. And it's always worth signposting people to this fantastic Asthma UK website where they have some excellent videos on all the different types and different brands of inhalers. So there's something like 15 different videos on there, which, I mean, it's hard for us as clinicians to keep up with that, to know 15 different techniques. That website's really good. And you'll find that link in the resources tab, so please do check it out. So after that, it's also worth, of course, thinking about non-pharmacological drivers. Do we have the right diagnosis? That's a whole nother clinic. Misdiagnosis in asthma is quite significantly high. That's why there's a big drive on objective testing in the most recent NICE guideline. And I mean, SIGN, although it's a bit sort of more under the radar, they do encourage us to do objective tests to try and make sure we can confirm it's the correct diagnosis. Don't forget about smoking, allergen avoidance. Always ask if they're actually complying with the treatment. All of these are really important. And then, of course, we think about altering the treatment regime. If someone's getting persistently poorly controlled asthma and everything else we've checked out and is okay, then we might need to consider changing the treatment. In fact, I'm going to come back to that slide. Let's just have a little think about the definition of control of asthma. This is from the BTS and SIGN guidance. So this is what they say we should be aiming for. Complete control. That's defined as no daytime symptoms, no nighttime wakening, no need for rescue medication, no asthma attacks, no limitations on exercise. If you're getting exercise-induced asthma, that is a marker of poor asthma control. Normal lung function, minimal side effects from medication. So that's the aim that we should be going for with all asthma patients. And we've got national guidelines to help with that. So if we do need to escalate treatment, we can follow the NICE guidelines or the BTS SIGN guidelines. There's international guidelines like GINA. So lots of respiratory specialists I know seem to prefer GINA, and some local areas, they kind of push them down that way. Actually, it'd be interesting to know, do you have a feel for what you use? Well, do you use local guidance, in which case is that based around one of these guidelines? Do you just use these yourself? You just follow the national guidelines? Maybe you don't have very didactic local guidelines. If you put that in the Q&A, it'd be interesting to know what you guys are using. Most of us will have some specific local guidance, and the benefit about the local guidance is that tells us about specific inhalers that we can use in our area, because there may be different you may have been able to get sort of different prices for different inhalers, and so there may be some preferable options in certain places. Let's just think about Sarah. So what have we learned from Sarah? So her control is not that great. So she often has flares in the winter. After she gets nerdy, she has exercise as a trigger. Both of those are a marker of poor asthma control. We know that she's underusing her inhaled corticosteroid. She's not taking it regularly as we would want her to. We know that with 4 inhalers of salbutamol in a year, she's overusing that. So the issues, we've got someone with poorly controlled asthma, SABA over-reliant, not using her inhaled corticosteroids regularly. I would say that potentially she is a high-risk patient. It may not actually be that she's got mild asthma at all. The fact that she's having these little exacerbations, even if they're not hospitalizing her, could indicate actually that this is a bit more than mild asthma. What can we do? Well, we can explore Sarah's understanding about asthma and her treatment as we've prescribed it. We can try to identify any barriers to taking the regime as recommended. We can educate her about asthma and the inflammatory nature of the condition, and therefore why it's important to use that regular inhaled corticosteroid. And once she's got that information, once she understands what the rationale is behind her treatments, then her compliance completely changes. And so she uses her steroid inhaler regularly. And over the next 6 months, her control does improve. Her requirements out for salbutamol significantly decreases. She's not getting further exacerbations. She's not getting that exercise-induced symptoms. Her exercise capacity is actually improving. She's running the fastest 10Ks that she's run in her life. If we were still having issues, if she was still poorly controlled, then of course we can escalate treatment. We can follow national guidelines. In the NICE guideline, maybe the next step would be add in some Montelukast, fine BTS, would be maybe consider switching to a combination inhaler. We've got options. It depends on which options you're going to be using. So, okay, let me hand over to Zoe for a sec. Zoe, any questions, any discussions coming out so far?
Any questions? Good grief, my fingers have not stopped typing, Neil. Thank you so much for all the feedback that you're giving me. So we've had, you asked the question, Neil, about what kind of guidelines people use. We've got some people using GINA, some people using BTS, using SIGN. I haven't seen anyone say NICE guidelines, interestingly, but we know that those other ones we've mentioned have certainly given us, more recent reviews. Lots of really good knowledge already amongst the audience about the importance of making sure around technique, making sure that if you are using an MDI, you must have a spacer as well. Don't let patients have a spacer without an MDI because the technique is so tricky to get. It just doesn't work as effectively. And we've had some really good sharing of resources as well. We've been talking about the Beat Asthma website that has some great videos of inhaler techniques on. We've talked about the Right Breathe website, and we've talked about the Greener Practice website. Loads of good stuff on there. We've also been talking a little bit about the challenges of when patients are struggling with asthma control, what we should be doing, and just really reinforcing what those national guidelines are saying about making sure that, as Neil said, we are aiming for total control of symptoms. So the first thing is making sure our diagnosis is really secure. In an ideal world, that would be through your gold standard testing, which is going to be pheno testing and spirometry. We know that access to those can be difficult at the moment. So the third line testing is going to be good old peak flow and then taking a really good clinical history. If you've then made what you think is a pretty secure diagnosis, you're going to be putting patients on treatment. You're going to be stepping up. Those steps up and steps down, they haven't changed. Starting off with a short-acting beta agonist, then going on to your inhaled steroids until you get that total symptom control. Nothing at day, nothing at night, nothing with exercise, nothing with cold. Only once we've achieved that and patients have been stable for a while would we even consider stepping them down. And you've got to really make sure they're keeping a detailed symptom diary, that you're not seeing any other symptoms flaring up. If they suddenly start getting symptoms when they're exercising, go back up. And so trying to get that balance, and then using the prednisolone as well if patients are struggling. Still some basic stuff that can be really challenging in practice. But yeah, loads of discussion. keep it coming. I know Neil's got some really helpful points he's going to talk about, and I will keep frantically typing in the meantime.
Thanks, Zoe. That's fantastic. And boy, yeah, I can see the amount of questions and comments and stuff that you guys have been adding. That's fabulous. Thanks. It's always it's hard work for Zoe, but it's great for us when we have such an engaged group. I love it. So, okay, let's think about Sarah a little bit more. So, she had a spell where things had been really good, and then gradually over time, her control seems to deteriorate a bit. She's using that Clenil regularly, but it doesn't seem to be just holding enough. So perhaps we trial her with some Montelukast. That doesn't work. We know maybe about 1 in 3 people get no response to a leukotriene receptor antagonist. She's maybe in that group. So let's stop that. We switch her out, and maybe we think about stepping her up to some MART therapies, a combination inhaler maintenance and reliever therapy. So I think we're all familiar with that concept, but what about the inhalers? So what would you prescribe, Sarah, if you were thinking about this combination inhaler? So I'm going to give you a really long list. This is all of the inhalers that I could find that were licensed for this indication, available in the UK. Some of them I hadn't heard of before, but do just say, yeah, I think you can only select one option here. What inhaler would you go for? And it'd be interesting to know, actually, maybe in your locality, they specify which one you might go for. That'd be interesting to know what that is. I'll run through the mix. We've got Symbicort Turbo Haler, Fobumix Easy Haler. I may not pronounce that right. Wok Air. I'd never heard of Wok Air before. It sounds like a budget Chinese airline carrier, but no, it's a combination inhaler. Duo Respirox Max, Forster Next Haler, Leforbec and Flutiform. Which of these would you think about prescribing, or would you be prescribing in your area? So I'm not making any commentary about the sort of the relative efficacy of any of these. All of them are likely to be very effective when used appropriately. You can see this list is posing more of a mental challenge for us because having a big sort of think about it. Okay, last few seconds. Let's have a look at your answers. Okay, so what's that? The largest group is Forster and then Forster Next Haler. So the difference there is the top one is the MDI and the Next Haler is the metered dose, is the dry powder inhaler version. At the top, we've got Symbicort. Everyone knows about Symbicort. It's been around forever. And Symbicort Turbo Haler. The Turbo Haler is the dry powder version. And then we've got a spattering of other stuff. No one's gone with Wok Air. That doesn't surprise me, given the fact it's entirely news to me. So we're going to have a think about how we choose inhalers for our patients. And the idea about this is not to tell you exactly which inhaler to use, but to set out the principles that we might apply when we're thinking about which inhaler could be best for our patient. So we'll come back to the greener practice guideline now. And there are some broad principles it suggests when we're thinking about inhaler prescribing after we've optimized our patient care. So they would suggest we offer dry powder inhalers or soft mist inhalers as first choice where clinically appropriate. So that's a broad statement for all respiratory care. You don't get a lot of soft mist inhalers in asthma care. You do get lots of dry powder inhalers. Why do they make this recommendation? Well, of course, it's because there's a huge difference in the carbon footprint between a metered dose inhaler and a dry powder inhaler. So a dry powder inhaler has about 1/40th, 40 times lower in terms of carbon footprint. And patients are interested in this information. They are interested in knowing more about their inhalers and maybe thinking about using ones that are more environmentally friendly. So in this recent survey that published the European Respiratory Journal 2021, so just a year ago now, 85% of surveyed asthma patients thought it would be appropriate to be encouraged to switch to a more environmentally friendly inhaler. 60% of patients who are on metered dose inhalers would switch to a dry powder inhaler for environmental reasons. Further 20% of that group were in the sort of not sure category. So maybe with the right information, perhaps they could be persuaded. It's only a minority of people that would maybe not want to switch. And beyond the carbon footprint issue, actually there may be clinical benefit of dry powder inhalers over metered dose inhalers as well. So this is a study published just a few months ago in Thorax. This is data from the Salford lung study in asthma, large study that's been running for a few years. And they recruited asthma patients who are using metered dose inhalers, and they were randomized to either continue with usual care. So, I mean, that could have been changing inhalers, but most people would stay on their metered dose inhalers, or switching them to dry powder inhalers. And the results showed that asthma controls consistently improved over 12 months with dry powder inhalers versus the usual care. I'm speculating a little bit here, but that may be, of course, just because of easier inhaler technique, and therefore they're getting simply more of the medicine to where it needs to go. Also, unsurprisingly, if you're making that switch, the carbon footprint goes down. So it halved in this study when they were switched to dry powder inhalers, but actually, even then, there were more opportunities that they could think areas where they could reduce that carbon footprint even more, some of which we're going to pick up on in a minute. So let's just think about good practice when we're considering inhaler choice. And the first thing to say is just we shouldn't be blanket switching inhalers. It is tempting to go into the computer system and just switch every single person from a metered dose inhaler to, for instance, the equivalent branded dry powder inhaler. But I definitely think that's a bad idea for a number of reasons. Clinically, it's not great. Those patients wouldn't get any opportunity to be given education about inhaler technique. There's no guarantee they're going to be using those new inhalers correctly at all. For some, it might mean that their asthma control actually gets worse, and if nothing else, it's likely to piss a lot of people off. So that's definitely not the way forward. What we really want to do is discuss the options at their next asthma review. Everyone should be having an annual asthma review, and we can chat about it then. I think it is helpful if we send them a bit of information in advance. So if we know that asthma review is coming up, you could send them some information about the different types of inhalers. Things like links to the Greener Practice group with really good patient information on are well worth doing. We then need to think, would a dry powder inhaler be clinically appropriate? So before we prescribe it as the default, we need to think, is this the best inhaler for that person? So it is good for many, maybe even the majority, but there are some situations where a metered dose inhaler plus a spacer would be maybe should be used instead. So if the patient can't take that fast, deep inhalation, if they don't have that sufficient inspiratory flow, then an MDI is going to be better. So very young children, the very elderly, perhaps those with very severe disease, sometimes they may struggle with dry powder inhalers. Patients who cannot or would prefer not to use a dry powder inhaler, you've got to work with the patient. The inhaler that's best for them is going to be the one that they use. So remember, the first step to the biggest difference you make is by optimizing their care. They've got to want to use their treatment. Number 3, where changing the inhalers are thought to outweigh the benefits. So perhaps you've got someone with quite nasty disease and they're really well controlled on their metered dose inhaler. You just don't want to rock the boat. That's fair enough. And then there's a whole discussion around the role of reliever inhalers and whether they should be metered dose inhalers and spacers. And we've always been told if you're having an acute asthma attack, an MDI via a spacer is the gold standard treatment. Actually, for many people who are not having sort of a very severe asthma attack, they're just having a bit of an exacerbation, they're going to use their salbutamol. A dry powder inhaler could work very, very well. But that's again, that's a whole can of worms that we haven't got time to go into this evening. And there's a whole debate around how we manage rescue medications in asthma that's going on at the moment. So the best inhaler is the one the patient can and wants to use. Check out your local guidance for the local options. A common question that we get asked is, are dry powder inhalers more expensive than metered dose inhalers. And there is this common misconception that if we're prescribing with the environment in mind, is going to cost the NHS more money, is going to blow all of our prescribing budgets. But actually, that's not correct, and possibly even the reverse is true. So, for many of the sort of very commonly branded inhalers like Symbicort, Forced Air, and so forth, they've got essentially equivalent metered dose inhalers and dry powder inhalers at same doses, same regimes, and an identical drug tariff price. And they've done that so that you can have the choice between the two. We've got data actually that shows it is possible to switch metered dose inhalers to the lowest cost equivalent dry powder inhalers and actually not just get large carbon savings, but reduce drug cost as well. If you're switching from maybe some of the more expensive branded asthma treatments to equivalent but lower cost asthma treatments, then that can save money financially. I wouldn't necessarily suggest that's what we want to do or have to do. It's all about getting the right inhaler for the right person. But it is possible to get people onto dry powder inhalers and to reduce costs. And also, this is a misconception that even I was fell foul of until recently. So for years, you prescribe salbutamol generically. The pharmacy would almost always prescribe Ventolin Evohaler. That is the classic blue MDI inhaler. And it's been the cheapest. It was the cheapest for quite a long time. But actually, lower carbon salbutamol MDIs such as Salamol are similar price now. In fact, maybe not. I was looking a couple of days ago in the BNF at the NHS drug tariff for Salamol, and it's marginally at a few pence cheaper than Ventolin Evohaler. So in fact, now almost every stage of asthma care could be cheaper and more environmentally friendly. Plus, we consider the wider picture. We want to reduce salbutamol use. So maybe if there are more expensive options, that matters less because we're going to be prescribing it less. And also think beyond the price of the inhaler itself, because if you get better control, people are ultimately going to use less medication. They'll have fewer visits. Every time they need to consult with us, that's a cost that we often don't factor in. Exacerbations, hospitalizations, those cost a lot of money to the health service. Less disease progression. The more you use your inhaled corticosteroids, including in mild asthma in the early days, you get less severe disease progression over the course of your life. That's going to have huge cost savings in the long run. And also just more days at work, in school, the wider economic effects are really, really important. And let's not forget that the data clearly shows that most patients, when we mention the environment to them, would be happy to try a lower impact inhaler. So all of the dry powder inhalers have a low carbon footprint. They don't have the propellant. They don't have those HFCs in them. They've got a low carbon footprint. So if that's what you're going to be prescribing, just find one that suits your patients. And there's loads of options out there. This is where the greener practice guideline becomes really helpful. So they've got a list of all the licensed inhalers in the UK, and they break them down in a very easy to use traffic light system. So green is a low carbon footprint, amber is medium to high carbon footprint, red is really high carbon footprint. So you can tell very, very quickly which inhalers from a sort of sustainability perspective may be better to be prescribing. They've also give you the regimes for low, medium, and high doses, depending on the severity of someone's asthma. Makes it really, really clear. So really, really good. Inhaled corticosteroid and LABA combinations. They've got the ICSs as well. So, I mean, you've got a whole 1, 2, 3, 4, 5, 6 different options there. You've also got salbutamol or short-acting beta agonist dry powder options as well. So there's loads of good information on that website. There will be times where we still end up prescribing metered dose inhalers. If that's required, then we might just want to think about choosing a brand and a dosing regime that minimizes the carbon footprint. So there are some specifics that we might want to think about here. So certain inhalers have a much higher carbon footprint than others. So we've already mentioned about salbutamol and Ventolin Evohaler. So because of the type of propellant that uses, it's got a really high carbon footprint. It's double the carbon footprint of something like Salamol or Aeromir in their standard MDI format. Ideally, avoid using branded Ventolin Evohaler. What else have we got? We've got Flutiform, Symbicort. Both of these also have this. So they have this much more potent HFC propellant in them, and so they're at the high end of the spectrum. They've got the highest carbon footprint out of any of the inhalers. So the advice in the Greener Practice website: avoid using branded Ventolin Evohaler, Flutiform, or Symbicort MDIs. There are lots of alternative options which we can use, something like Forster, Steritide Evohaler, Combisal MDI. There's lots of other options that are out there. But it's really important that you prescribe it by brand, and that includes for salbutamol as well. So typically, I've always thought it's best to prescribe generically for salbutamol from a cost perspective. Actually, now when we're thinking more broadly, including for cost, I guess, as well, it's actually better to prescribe it branded. If you put it as a generic salbutamol, they'll probably end up getting more Ventolin Evohalers. Then you can also tailor the regime to maximize the number of doses you get out of an inhaler. So, for example, you could prescribe just one puff of 200 microgram Clenil twice a day, fairly standard dose, instead of using what we would more commonly prescribe of two puffs, 100 micrograms of Clenil. So you would then you're halving the amount of drugs that you're using for the inhaler, and therefore you're halving the amount of impact on the environment. The patient is getting the same amount of treatment. And this is where the Greener Practice guide comes in really handy as well, because it gives us those more efficient regimes. So from a cost perspective, it's normally cost neutral because they typically price the inhalers as they double the strength, they double the price. But from an environmental perspective, it's much easier, much better. And from the patient perspective, it's often much easier as well. The less someone has to take a medication, the more likely they are to comply with it and use it in the correct way. And then the last thing we can do is think about advising on disposal. So here's a question. Let's do another poll. Do you routinely discuss the disposal of inhalers in your asthma review? So is this a standard part of your asthma review? Okay, let's take a look at your answers. Okay, so 90% of you would say no, and I'm exactly the same. So no, until now, it really hasn't been on the agenda. You're thinking about all these clinical things. Talking about disposal is the end of a long list. The reality is most inhalers go into the household waste. They just get stuffed in the bin when they're done. The problem with that is that there's leaching out of these HFCs over time into the atmosphere. What we really need to do, this is the second best option, but this is the sort of most likely option at the moment. We really need to incinerate them. So counterintuitively, burning inhalers is actually better for the environment because it degrades the HFCs into far less potent greenhouse gases. And so if patients know, they need to know that they can return those inhalers to pharmacies where they can then be correctly disposed of. Recycling is definitely the best way to go. There's not a lot of recycling schemes around at the moment. It's worth checking if there's anything in your area, and some pharmacies may have signed up to, I think there's something still going on with one of the drug manufacturers Is it Tiva? Someone will be able to tell me in the Q&A, I'm sure. And they are running a paid-for recycling scheme that pharmacies can sign up to. It's largely a mechanism to get them to use more of their inhalers, I think. But if you recycle the inhalers, you can take out the remaining HFCs. You can reuse those in other industries, which is obviously better from a life cycle perspective. We've got a few minutes left. Let's think just beyond prescribing. And we're going to quickly think about education, practice income, and quality improvement. So I'm going to bring us back to the Greener Practice Asthma Toolkit. It really is a fantastic resource. And one of the best resources on there is this suite of videos that they've got, which is takes you through various different aspects about asthma management. One of the best ones is the video that I've got in the middle here. So this is done by a lady called Carol Stoneham. She's a respiratory nurse. She's actually the chief executive or executive chair, maybe is the right phrase, of the Primary Care Respiratory Society. She's the head honcho. She's done this fantastic video on a gold standard asthma review, which taught me quite a lot, actually. If you watch no other video, watch that one. It's really, really interesting. And then there's loads of extra resources on quality improvement and sort of financial issues in the practice as well. So this is my last poll for you today. Let me ask you a question. If you're working in England, has your practice signed up to the PCN DES Investment and Impact Fund? Are you doing this as part of your PCN? So A for yes, B for no, C for unsure. Is this something that you're aware of being involved with at the moment? Are you sort of like going all guns blazing with PCNs? Are you kind of scratching your head and just wondering what on earth we're trying to do? Just get through the day. Are you? Do you know if you're kind of part of this at the moment? For those of you who are outside of England, are you looking on at all these different sort of hoops to jump through thinking, I'm glad I'm not there? So we know. Okay. So what's that? 40% of you, yes, you signed up. Quite a lot of you are unsure. So this Impact Investment Fund or Investment and Impact Fund, actually, some aspects might be quite hard to achieve, but also there's a lot of good stuff in here. And this is something that NHS England has come up with specifically to try and improve certain aspects of clinical care beyond what we've got in QOF. And there's a lot of good stuff in here because there's a big focus on good asthma care. And there's also a focus on being environmentally sustainable in the NHS. And in terms of what we can do in primary care, one of the best things we can do is think about the inhalers that we're prescribing. So there's a whole different range of criteria here. Those percentages of people on that QOF asthma register who are receiving 3 or more inhaled corticosteroids in the last year, 6 or more short-acting beta agonists. Those patients, of course, are going to be high risk. The percentage of metered dose inhalers prescribed for all of the different inhaler prescriptions that you're doing in the over 12 category. Remember, we're not really thinking about the kids today. That's a different conversation. And also the mean carbon emissions per salbutamol inhaler prescribed is an interesting one. And maybe trying to drive use of those lower carbon salbutamol inhalers if we are going to be prescribing MDIs in that perspective. So I think there's a lot to be said for the IAF. And I guess what it's sort of trying to do is it's kind of doing quality improvement whilst financially incentivizing practices to do that, which is generally, I tend to think is generally a good thing. I mean, when we think about quality improvement, if you're doing the IIF, that's a good place to start. The Greener Practice website has a really extensive quality improvement section in there, which I think is absolutely fantastic. If you're thinking about doing some quality improvement, if you're struggling to have an idea for your next appraisal, go to this page. It's linked in the resources tab list, and they've set up. There's a whole range of different projects they've done. They've broken it down into stepwise processes and lots of resources for each of those projects to make it really, really easy to try and do some really good respiratory care quality improvements. So things like if you're trying to address SABA overuse, go back to basics. Who's actioning the prescriptions? That's information we need to know before we can make any changes. How do we identify over-reliance? Can we provide information to patients? Can we invite people in for asthma reviews? And crucially, they have these fantastic text and letter templates that they've already done. So all the hard work's already done for us, which then you can use to help with your patients as well. And they've done it for loads of different things. And I think it's absolutely, it's really, really fantastic. So we're almost at the end. We've got just like 1 or 2 minutes for a very quick bit of rapid reflection. So maybe just let me know in the Q&A one thing that you found really interesting today or you didn't know before or may change your practice when you're at work next. Put that in the Q&A. I'm going to take a quick look at it before we just go over to Zoe for more of your comments and questions. Zoe, let me bring you in.
Oh, I need to lie down, Neil. Okay, I'm going to try and just rapidly whiz through these. You have been brilliant, not only in asking questions, but in supporting one another, because I've pinged some questions back and forth. Rosie, you asked about training resources, and I've got millions of them now, so I'm just going to whiz a few off for you. Clinical Innovation Adoption, Oxford AHSN will soon be releasing a template. We've got recommendations about some training from the Primary Care Respiratory Society, that being really helpful. E-Learning for Health has got a good asthma course on, a course through NES for annual reviews of asthma that was available on Taurus. Primary Care Respiratory Society again. Loads and loads of things. Educationforhealth.org. Primary Care Training Bradford do a good asthma course. Education for Health. Distance Learning from the University of Cumbria Respiratory Health Assessment. Oh my goodness me. So hopefully, Rosie, that is helpful. On top of that, we've then had lots of feedback, Neil. Some areas where recycling inhalers is really easy. Other areas where some pharmacies are not taking them, so it's really difficult to direct patients anywhere, and that being challenging. Some places have stopped doing recycling. Some pilots have been going on. Lots of reflections on why patients sometimes don't want to switch inhalers, to do with everything from prescription costs to the taste of certain inhalers. I've said if it tastes bad, you know it's working. That is the law. That's what Mary Poppins taught us. And so many learning points coming in. So I'm really going to try and get all these questions just finished off as Neil as Neil finishes. Thank you so much. I can't promise to get to all of them, but you've been absolutely brilliant. Do have a look at the websites in the resource section that we've signposted to.
Yeah, thanks everyone. It's been fantastic. And just 2 quick things before we go. Firstly, I'm going to come back to the rapid reflections very quickly. But we're doing another one of these free clinics in a month's time. We try and do them every month. Next time, we're going to be doing managing shoulder pain in a world where lots of people are getting musculoskeletal problems after they're coming out of lockdown. And with our lack of ability to refer, this might just be the ticket. So do have a look at that. Also feedback. So when we finish this, you'll see this little icon come up. If you've got a minute or two, there's a very quick questionnaire about what you thought about this evening, the idea about the clinics, how we do stuff online. Your feedback's really, really important to us. We've changed our courses. We've tried to develop and improve them over the last 20 years based on what you tell us. So please, if you've got a moment, then that would be fantastic to fill that in. And just coming back to that last bit of reflection, because I know I've overrun. I'll be honest, I thought we had way too much not way too much to fit in, but there was so much I wanted to cover. And we're trying to cram in a lot of stuff in a short amount of time. Just the rapid reflections, lots of people talking about, I'm really pleased. Lots of people just saying they didn't know the level of environmental sort of impact, the difference between dry powder inhalers and metered dose inhalers. So I'm really pleased that you guys have come on this evening. Lots of people talking about the useful to know between the lower carbon alternatives to Ventolin Evo, Halo, or salbutamol prescribing. Lots of people talking about just telling people about disposal of them, the appropriate disposal. That's really good. Lots of people talking about the Green in Practice website in general. Please do check it out. Please do join the local group, or start one as well. But I just did it with me and another person, and a bit of hope. It doesn't take very much, and that's fantastic. Remember that this is going to be on demand on the website now into the future. So please do share it with your colleagues. Please do come and have a refresher if you want. You can also access the resources tab. That'll still be there. You just log in as if you're going to watch it again, and you can get access to all of that. And thank you so much for giving up your time tonight. So I'm going to let you go and enjoy the rest of your Tuesday evening. Thank you for Zoe, whose fingers may be worn out. She'll never need to worry about getting fingerprinted again in her life. And it's been great to have you. Thank you so much, everyone. Good night.